right, and we are ready to go. Hello, everyone. Thank you for joining the Center for Learning Health System Sciences for our monthly impact seminar. Before we get started, I'd like to cover a few expectations. Today's seminar will be recorded. You can enable closed captioning by hitting the Show Captions button next to the Raise Hand option in the Zoom menu. The public slide deck will also be made available on our website under the Education tab. I will post the link in the chat along with a short questionnaire asking for seminar topic and speaker suggestions. Following the presentation, we invite you to raise your hand or type questions in the Q&A. And in particular, we are welcoming questions exploring the many dimensions of impact that these ideas, technologies, and practices have on learning health systems. As a reminder, for our upcoming LHS events, the next seminar will be August 6th with Dr. Tiffany Bright from Cedars-Sinai. And with that, I will turn it over to Dr. Genevieve Melton-Mukes to introduce our speaker.
Hi, everyone. It is my distinct pleasure to be able to introduce today's seminar speaker, Dr. Jeanne-Marie Guise. She serves as the director for the Center for Healthcare Delivery at Beth Israel Deaconess Medical Center and Harvard Medical School. She is the director for the Massachusetts Institute for Equity-Focused Learning Health System Science, and that is a statewide collaborative with multiple institutions and alliance of hospitals, community health centers, and safety health clinics dedicated to accelerating research and training a future workforce in learning health system sciences. And it's one of 16 that have been designated as centers of excellence in learning health system science. She is by training and now a physician scientist who has expertise and a proven track record. She's led very large research initiatives, including multi-center studies and mentoring training programs. And her research, as you'll hear some about today, aims to improve healthcare delivery and patient safety, both inside and outside of the four walls. She was trained as a medical doctor at the University of Washington, completed residency in obstetrics and gynecology, and also completed an MPH in epidemiology as a National Research Service Award Primary Care Research Fellow at UNC Chapel Hill, and then also completed a healthcare MBA from Oregon Health Science University and Portland State University. And so I think one other thing to also note is she's the co-founder and co-chair of the U.S. Cochrane Network and really has an amazing track record of mentoring, including leading several highly successful institutional research development programs for mentoring faculty. I'm really excited today to hear her presentation, and please join me in welcoming her. And she's going to be talking about Beyond the Norm, Human-Centered Design, and the Power of Outliers. So with that, thank you, and looking forward to it.
Thank you so much for that really kind introduction, and thank you for having me. I'm just going to try to share my screen right now, and then I would love it if somebody could tell me if you see the correct. You see the slides as slides? Fantastic. Okay. And then let's see. So thank you also to the participants who are here today. I really appreciate you being here. I do have some, just as a warning, there are some opportunities for interaction, and I'm hoping that we'll be able to do that. I'm just trying to get my screen correct here. So that, there we go. You can see it moving, right? Okay. So thank you again. I have no financial disclosures, but I do want to express sincere gratitude to Jamie Peterson, who is one of our LHS K-12 scholars, and Lily Horner Johnson, also one of our P-Core LHS core scholars, for sharing allowing me to share with you some of their stories and experiences. What I'm hoping today is that I noticed that this particular series asks us to think about the impact we want to have in the world in doing the research that we do. So I want to talk a little bit about that. I'm hoping that we can do a little exchange there. I really want to start exploring the role of patients and the public in research, and then discuss the value of potentially using a business approach called human-centered design in LHS research to engage the patients and the public. So I'm hoping that you can type in the chat what your why is. What is the impact that you're trying to have in conducting learning health systems science research? Here, I'm hoping that some brave souls will put in some of their hopes and aspirations. I can tell you what some of mine is that we do a lot around pre-hospital care. And so a lot of my work, whether it's in pre-hospital or in the hospital setting, is trying to address the preventable errors that occur during the delivery of care. So we know that that's either the third or fourth, it's a leading cause of death that's unintended. And about a little over half are thought to be preventable. So working in the ways of improving our systems and our technologies to make things safer. We have making healthcare delivery easier to navigate, making surgical care safer, changing the narrative on parental mental health, and make the next generation of parents have a better experience than the current and past. So I'm going to keep going, but please continue improving equity in healthcare settings. Great. Please continue to put in your why. I think it's going to be really helpful it's helpful to me. I like to know who we're talking with, and we can talk about it again as we continue to go on. It's always great too to see such a great balance of different interests as far as surgical and clinical and mental health and operations. It's really neat. It's one of the great things about learning health systems science. So what is learning health system science, or what is a learning health system? So it comes back, the original definition comes back from an IOM work group. That's now we call it the National Academy of Medicine, but it was, or the National Academy of Science, Engineering, and Medicine, but it was the Institute of Medicine, where there's this idea of putting science, informatics, incentives, and cultures aligning for continuous improvement and innovation. And then for AHRQ, which is the funder for both your program and our program, a health system in which internal data experience are systematically integrated with external evidence, and that knowledge is put into practice. And with this nice little graphic. So that's probably the most common way of thinking about it. So how did we get here? How did we get to this place where there's really quite a focus of getting data, data in, data out, data around? So if we start going through the background at the time, say 2006, we know that the US spends a lot in healthcare. We spend more than any other country, I believe, certainly any other developed country. And we see here, if you start looking even at 2006, you can see the gap is getting wider and wider. So certainly healthcare was getting very expensive and continues to. On average, we spend about twice the average of other developed countries on healthcare. And unfortunately, we're not getting twice as better outcomes. So if we look at this, you see that in the top quadrant, you have the lowest spending, but the highest life expectancy. Over on the right top, you have high expenditure, but high life expectancy. The bottom left, you have low expenditure, low life expectancy, and then we are out on our own with high healthcare spending and low life expectancy. And if we start looking at what's preventable, we also are in the wrong direction as far as preventable mortality, meaning that it's treatable or preventable, meaning that our spending and our avoidable mortality are both high. And then if we look at the various parts of the US, they are all affected. There isn't a place that's better than others, and each of our sections are also worse than, say, the EU. And certainly at the time, we don't hear it quite as much now, I think, but certainly at the time, there was a lot of discussion that it takes 14 to 17 years for evidence to get into practice. And unfortunately, even with technology, with the computer technology, this is still quite delayed. We have information that 1 in 10 medical treatments is backed by high quality evidence, meaning 99 out of 10 are not. There's questions about the overall quality of healthcare that's delivered, with about half receiving the recommended care. And then there's been a lot of debate over, oh, is it 7 years? Is it 14? Is it 17? So there was actually a meta-analysis done of all the studies that tried to look at how long is the lag. And they said it is a 17-year lag getting evidence into practice, which is really sobering. It's hard for those of us that are doing research and also those of us that do clinical care and research, thinking that we want to be a lot better than that. But certainly you can see then why people are saying, okay, we've just got to get the evidence that we know is out there into practice. We've got this big gap. And at the time, we also had the triple aim of healthcare, meaning that healthcare should promote overall health. It should be patient satisfaction and lower costs. And so this idea around learning health system science, so then there was this focus. So we had the idea of learning health systems, and then this idea of, okay, if we need to get data into practice, who creates data? Researchers create data. If we could bring healthcare operations together with rigorous research, then we would do the kind of healthcare delivery and research that actually matters and translates into practice. And as a result, we would get higher quality care, safer care, et cetera, and better places for everybody to work. And then we have these core competencies then, as far as, okay, those align as well. Systems science, research methods, informatics, improvement science, equity, justice, et cetera. But overall, data tends to make us focus on the average. We go where the money is, right? We go where we can start to adjust for this, that, and the other. Even when we deliver health policy, we often say for the average patient or for the general population. And so sometimes those little dots that are on the outsides aren't getting as much attention. So my question is, could we learn something from business? And that's one of the focuses of the Massachusetts Institute for Equity Focused Learning Health System Sciences. In specific, we're wondering, could it be helpful to bring human-centered design, which is something that's been really common in business, used for decades, and something that I certainly learned during my MBA? Would it be helpful to learning health system science? And might it actually be something that would be helpful to promote equity? So I would love for you, again, to put your answers in the chat here as far as, do you currently engage patients or the public in your research? Or if you're just starting, you can say if you plan on it. And then, have you received formal training? And would you like to have had formal training if you're already engaging, but you didn't? Or would you like to have it if you're just starting out? Give us all just a little bit of time. Yes, some engagement directly with patients, some training, could use or would like more. CBPR training through an organization which is community-led. Participatory research projects, including patients who had formal and informal training and patient engagement. Okay, and please keep it coming, and I'll just keep going here. So overall, I have a question for you as far as what kind of spaghetti sauce do you like? And you don't have to type this in the chat, but just think about it in terms of what is it that you particularly like. And you may have heard this story. Malcolm Gladwell, who has written the books on Outliers and things like that, talks about this story about Howard Moskowitz. So Howard Moskowitz was somebody that specialized in the marketing around what people like, people's taste and foods and things like that. And he initially got his start working for Pepsi, where Pepsi had asked him, evidently they knew ahead of time that the ideal sweetness that people like is between 8% and 12%. That if you had anything less than 8%, it's not sweet enough. And if it's 12% or over, that it's too sweet and people won't like it. And they had a new artificial sweetener, aspartame. And they had asked him, okay, so we know it has to be between 8 and 12, but where? What concentration when we release this new Diet Pepsi should we have it? And you would think you might just say split in the middle because it's an even number or whatever, but he took samples all the way from 8, 8.1, 8.2, et cetera, all the way to 12, took it out to thousands of people and had them taste the Pepsi. And he came back and said, well, it turns out you don't need just one kind of Pepsi. There's evidently you're going to need multiple Pepsis because the results that he got did not line up. There wasn't like an answer. There wasn't even just a few answers. Well, they didn't like that answer. And so he didn't keep his job there, but then he got hired by, I think it's Campbell's that makes Prego. At the time, ragu was like the key spaghetti sauce, and they only made the one kind. At the time, there weren't all that many selections as we have today. And so they similarly said, they felt like they had better quality ingredients, but they just could not beat ragu. And so they went to Howard and said, hey, what can we do? And he once again made many different formulations, or had them make many different formulations of spaghetti sauce. And he took it out and had people rate from 0 to 100 the sauces. And then he came back, and what he found was that people liked traditional, they liked spicy, and they also liked extra chunky, which at the time did not exist. And so then Prego made the extra chunky. He similarly said, basically, you need multiple types of tomato sauce. And they came out with extra chunky. And then after that, then they took over the market, came up with now, I don't know, I thought something over 36 different flavors of spaghetti sauce. So then perhaps we're doing the same thing. Perhaps we're trying to, perhaps there's not just one perfect healthcare system. We have this information that more than 70% of Americans feel like they're failed by the healthcare system. The life expectancy gap is widening between men and women. There's issues with long wait times, short appointments. We have hospital bottlenecks in the ERs for probably all of our various systems. So the system really isn't working for even probably the average or the general population. So this question of could we take a different approach? So is it time to go beyond the average? Instead of just looking at where all the data are, could we start looking at the margins and centering on the margins? And might we, like Howard Moskowitz, find that once we start looking there, that there's groupings of people there that would help us make our product even better. And in this case, the product is healthcare delivery. We now know as well that the aim is the quintuple aim from the IHI, which is with equity in the center. And so for us in particular, we thought that this approach of now saying, hey, could we make our product even better by paying attention to the groups that have traditionally been at the margins and giving voice to that also would promote equity in terms of the quintuple aim. And a great example is are the sidewalk breaks. So that was initially back during the ADA legislation, and in particular for wheelchair access. However, we know now that made something better for everybody. If you have a stroller, you have luggage, you have bikes, you have scooters, like it is benefiting everybody, these curb breaks. Similarly, women in the workforce have created a lot of changes in terms of the workforce. So there's a lot of examples where when we pay attention to groups that traditionally have not been the center, they make the product better for all of us. We all benefit. So then I thought I'd go over just a little bit about what is human-centered design, what are the elements, so that then I'm hoping that when we get to the end, we can really have a meaty discussion around whether this might be something that's useful, whether you've used it, and how you found it useful. Probably IDEO is the most well-known company for human-centered design. They did a lot of work with Apple. They did work around Apple's mouse and other things with Apple. They're out of Stanford, and their ingredients include first empathizing, learning about the audience, then defining, trying to get an understanding of what are the needs of the audience, then brainstorming or ideating to come up with many possible solutions, and then coming down to the one that you think is the best as a prototype, and then testing it to see if it works. The second approach is known as a double diamond. Similarly, you go out and talk with a bunch of people, get some ideas of needs, then you start to converge back down again by defining groupings. Then you start to go out again in terms of the brainstorming, and then converge again around coming up with a product. So the first then is empathy mapping, which is really trying to understand the pain points, the barriers, the workarounds that patients face in their journey. This is a map that's often used where you have kind of the person and you're trying to think about what do they see in their environment, what do they hear, what are they trying to do, what do they say, what are they thinking and feeling, etc. So you could imagine like maybe your parents and you're trying to get into a clinic with your child, and maybe maybe English isn't your first language, and reading and the signs can be very difficult. It's very easy to get lost in hospitals in general. Kids certainly can't necessarily read at the time. And so you start to understand, okay, they're lost, they're frightened, they don't know where to go. They, are worried about being late, et cetera, et cetera, et cetera. And what could you do then? You're getting a sense of here's somebody that's trying to navigate the healthcare system. And even when they walk in the door, it's really challenging for them to get even to the clinic where they could get some care. One of the advantages, so then you talk with people and you get to kind of walk through that, to basically walk a mile in their shoes and understand what it's like. This is an example of a persona. We did some work during my MBA with the community centers, and they in particular were working on, they were concerned about no-show rates in clinics. And the clinics they wanted were primary care, surgery, mental health, and one other. And so we found all sorts of data, and we started to do interviews of healthcare providers and healthcare operations folks in terms of the priority. It was a priority to the health system. Was it a priority to the clinic? And where did that fit with everything else? And then we also started to look at those data and said, okay, we want to start interviewing some of the patients, that the group where it looks like you're scheduling appointments and they never show and they never show and they never show, versus this periodic person versus they scheduled once, et cetera, to understand. And so then this is just one of the personas where you can start to now put a story around the data, because it was really easy for people to say, oh yeah, this is just somebody that never shows. And then to understand, well, what's going on? What's behind all of that? That they recently moved, their partner has a job which takes them out of the house most of the time. Parents passed away. The partners live across the country. She's worried about her newborn while the partner's away at work. So there's all of this, you know, she's afraid of missing appointments. She's not able to handle it on her own, all of these kind of worries, and also issues around how am I going to get to clinic, because there's a lot of other challenges in her life to get there. So then there's the next piece that we were talking about as far as brainstorming. You want to get as many diverse ideas as you can. You don't want to censor any. So the idea here is volume. You just go for, a lot of times there will be a beginning of a sentence that said, how might we improve the clinic systems so that people could get to the pediatric clinics? Well, we could send them an email ahead of time. We could have people standing in jackets right by the front door saying, can I help you? We could have animals next to each of the clinics so that each clinic was known as an animal, so that then all we'd have to say is go to the giraffe clinic and a kid would recognize as well, oh, the giraffe clinic, etc. So you just throw out all these different ideas and you're just going for a bunch of quantity. And then eventually you come down to your prototype where you're thinking, okay, I think I've got it now. Here's something that might work. Let's test it out. You create a little bit of a storyboard to understand what might be happening, and then you test it. So I thought that it can always be helpful to have some examples. And so I, once again, am so thankful to our scholars. So Jamie Peterson is a pediatrician at Oregon Health and Science University. And before becoming a doctor, she was actually a teacher. And so she has this real passion around how children learn and how overall we can help children to get a better start. And realizing that pediatricians will interface with children for many years before they're in the school system. So is there some sort of way that could be helpful, again, around the social drivers of health, to help everyone get access to a better start? So then she started engaging parents, providers, educators. She has research assistants, students, community partners, all sorts of folks, mostly that are speaking both English and Spanish, as her particular focus is around people who speak Spanish primarily and how they might get a head start. So then she intentionally designed her whole study with parents at the center, and then started to understand, like, what are the needs and where do they go? So she started to find out, okay, well, families do trust their pediatrician, and it's one of the greatest treasures is their children. So they care desperately and they do trust their pediatrician. So that's a good source of information. With the first one, when she was little, I didn't read anything. Now that she's big, I try to spend time with her. So she starts getting all these stories and then gets like the major developmental milestones for children to start understanding what does this community need and what might be beneficial. Then starts to map the whole thing out. She's like, they had pictures and Post-its and all sorts of ways of starting to communicate those stories. And they put them up and then started to kind of make a journey map, started to bring some of these themes together. And then also started sharing the information with the staff. And you can tell, again, there's a lot of pictures that are using to create these stories so that now the data have meaning as far as stories. And together, through this entire process, they came up with a texting app was one of the things that was most helpful to the families in terms of getting kids ready for school. The second example I wanted to go over is Willie Horner Johnson. So Willie Horner Johnson, an epidemiologist who also works at Oregon Health and Science University, and she's director of the Center for Disability Research. And this is an R01 now. So she was a P-Corps scholar and now has her own R01 and specifically is engaging patients with intellectual and developmental disabilities. And these are some of their slides that actually, even the slides are put together by both and presented by both the community partners as well as the researchers. So overall, the purpose of the project was to create a phone app to help people with developmental disabilities make decisions about getting pregnant or not. So one of the things that they found is that a lot of times when people with intellectual and developmental disabilities that affect cognition would go in for care, the focus would be on a specific condition and not necessarily thinking ahead about the rest of life and what they might be planning, that they could even get pregnant, etc. And similarly, patients are wondering, do they want to get pregnant ever? Do we want to get pregnant soon? Do I want to get pregnant at all? What if I don't? What if I don't know? Who would I even go to get information? So the steps were included interviewing patients about making decisions. How do they make decisions whether or not to get pregnant? And then doing a national survey and then making and testing the app. Those are the big kind of general steps of the research. She developed a community partner board that consists of 7 women with intellectual and developmental disabilities. And they come from all over the US. Some have children, some don't have children, and they're paid for each meeting. They meet at least monthly. And it depends on how much needs to be done, and they participate in the entire project. So one of the things, they were creating an infographic to try to then get information from patients. And you can see on the left side is before they ever partnered with the community board, this thought of, okay, we want to provide some information that with a certain, if you are sexually active, how many people would get pregnant in 1 year if they use no birth control? And so you can see this kind of, that was their graphic. And then over on the right is after with the community partner board, then they've rearranged things. So they said, okay, we actually want all of the data to go together. So over the next year, if 100 women are sexually active and do not use birth control, 85 will get pregnant. So you can see that before it was split up with the graphic in between. Then they also had suggested, hey, they found that the colors were harsh on the eyes. So they wanted to change the color. Plus they said, hey, these look the same. And it would be helpful if we knew that some of those are actually pregnant, some are not, if we broke it up so that it's really easy. You could count it out if you wanted so that you can have multiple ways of getting the same information. And also that it looked very gendered on the left and is less gendered on the right. So you can see a lot of times I think we engage patients and the public because we really believe it's going to make things better. And sometimes it's really hard. You know that it did make things better, but because it's part of an evolution, you might not be able to identify. But this is a really great example, a very concrete way that the community partner board made it much easier for patients to understand. And I would say that that would be a better graphic for anybody, not just people with intellectual and developmental disabilities. And so overall, I think that part of this is about we want the data, we need to get data into practice, but it's also about the people and the relationships and the connections and the humanity. And could that combination of data along with the stories help us to make a better healthcare system? And interestingly, if you go back to the original, so what I showed you initially is the part that we all focus on as far as what is a learning health system. But in 2006 even, you can see where not only did it have the part we all know, one in which science, informatics, incentives, and cultures are aligned for continuous improvement with best practices seamlessly embedded in the delivery process, but it actually did say individuals and families, active participants in all elements. So I think even the vision back then was this idea of combining all of that, which I know is a focus of the learning health systems, science, centers of excellence, and the healthcare, the training programs that we're all in or a part of or graduated from. And I think it was part of the original vision before. So I'm hoping now to really have a great conversation with each of you in terms of this thought around, could human-centered design be helpful? Do you think that paying attention to the groups at the margins and really changing our focus could be helpful in terms of the redesign? In what ways? Probably some of you have done some of this work and have a lot of great insights to share. And I would just love to, again, revisit the idea of the impact that you all want to have that you've shared there. And thank you so much for sharing that. And whether this approach or others that you've found useful would be helpful as far as patient and public engagement. Thank you. Let me get to where I'm not sharing. There it is. Stop sharing.
Wonderful. Thank you. We have plenty of time for Q&A. If you have questions, please either put it in the chat or in the Q&A box, or you can raise your hand and we will unmute you. All right, there's a comment from Tammy, and they said, I think it would be incredibly helpful and meaningful. While not always research-based, we've seen great results when we take the time to hear from the people that leverage our digital tools.
Yeah, it's interesting that that person brought up the digital tools, right? Because I think it tends to be a little more common that you think about design thinking when you think of creating digital tools. And we don't necessarily think about it for some of the other issues as well, that it can be helpful just in general as an approach. One of the issues that sometimes comes up is that in human-centered design, if you follow it specifically the way that it's often kind of a roadmap, the thought is that all it takes is that you would engage 3 to 5 individuals and that should be enough. And usually in our research side of things, that's not enough people. So there are other mechanisms where it's not uncommon at all that people will do big surveys or focus groups. Certainly, as we've been applying it more to research, those numbers tend to be bigger than the 3 to 5.
Yes, Genevieve.
I really enjoyed the talk and love the overview and also seeing some of the case studies with the 2 scholars. Sometimes, at least, and maybe I can just comment personally, one of the pieces that's difficult is kind of knowing where to start, and even that question about training, like what's the right training. So just curious about advice that you have around that, where to get started and how to get a good foundation.
Yeah, thanks for bringing that up. That is one of the tough things. There was a study actually out of Manitoba where they asked questions about patient engagement and training in patient engagement and whether people would want it. They asked them to rank, like to rate how experienced are they in things. And so a good amount of people, like more than half, had actually engaged patients. And of those, very few had formal training. And then when they really got down to it and started asking people, the hardest thing, and I think especially now, is time. Like we have so many things pulling at our time. And I think that's part of, I can say what we're doing right now is formulating an intensive that'll be a week-long intensive to at least introduce some of the skills. It's one of the things I think that one of the reasons we think that human-centered design can be useful is because it can be taught, and that I don't think it takes a huge amount of time to get the general principles and get started. I have noticed, as somebody that's been helping folks with this now for over a decade, that a lot of folks will go from human-centered design, and as they get more and more experience, they do transition, it seems, over to CBPR, where it's more and more and more engagement. So I don't know if that's, I take it as a good thing that means that they're finding huge value in engaging patients and want to do even more. But it is an issue of just no matter what it is that we want to train, how do we do it? How do we find the time? Because we know you have to do research, you have other stuff you're trying to do, and you're learning. And in this learning health system world, there's a lot to learn.
Yes, Melissa said, I also think human-centered design is incredibly important, as is patient engagement and research. I've noticed some funders weren't as interested in participatory research in recent years, but that seems to be changing.
Yeah, I agree. I think since PCORI's been here for now, a decade, I think that it has gotten more common, the impression that patients need to be engaged, and that more engagement is good. It's hard, right? It's hard for all of us. There's that thought. I remember when we first started teaching some of the patient engagement, which was back when before even PCORI got started. Somebody from the board from PCORI had said, it's not like I want to stand by my mechanic and watch every single part of what he's doing to fix my car. And so similarly, patients have other jobs and they don't want to have to, like, if they wanted to be a researcher full time, they would have gone to train in that way. And so it's that balance of trying to figure out how do you respect their time and get the involvement that you want because you value all of that, but also recognize this is coming at a cost to them too, because they have full lives, jobs, etc., a lot of obligations. But I agree. I think the funders are more and more looking for that. And the more that learning health systems and PCORI kind of stuff becomes the traditional route, the more we're going to see engagement of all sorts, right? Interest holders of all sorts to become a priority.
All right. Once again, if you have questions, please put them in the chat or the Q&A or raise your hand. We will wait a couple moments to see if any come rolling in. But in the meantime, our next seminar, once again, is August 6th at noon. And oh, we have one more comment from Mary Butler, who I believe you know.
Oh, I do.
Yes. Mary said, oh, and now, okay, sorry. We had a staff person at the EPC who took a week intensive in UX design because she wanted to improve patient engagement from a patient perspective.
Great.
And a question from Dylan. They say, good presentation. They have a quick question. It seems patient journey mapping is more research with patients to develop from learning health systems. However, there might be linkages to electronic records, but patients do not receive mapping from physicians at a hospital or clinic. Are patient journey mappings a major part of learning health systems from your perspective?
Wait, so let me just see if I can see that. I'm trying to make sure I understand. So the idea is around journey mapping and that in electronic health systems, they're not mapping. Is that the thought?
Just reflection that there might, no. Is patient journey mapping important to the learning health system?
Yeah, I sure think so. I think so. I mean, that's I think where we're focused because our particular learning health system is focused on equity. And I feel like the empathy mapping and the ability to create personas allows you to keep that at the center of what you do so you don't lose your focus. Because it's pretty easy to get taken away by other things. So I think it's important. I think personally, that we are coming back to the need to be connected again. That healthcare delivery is a connection, it's a relationship, right? And electronic health records are great, but we certainly saw the times when our backs are turned to patients as we're entering information. And there's been a ton of data, and there's apps and all sorts of things. And I'd like to think that we're coming back towards that need, that reminding that we are connected and relationships are important. That trusting relationship is an important ingredient to getting better, to healing, and that comes from the human connectivity.
Layla wanted to know, are there any best practices or frameworks to use in how one can test and iterate HC design, keeping in mind the marginalized communities you would want to test your tool might have priorities that limit their participation?
Yes, yes. I think there is a group, and the name of the group is not in my head right now, but there is a group that specifically focuses on equity and healthcare design. It's around racial justice and human-centered design. They're out of DC. And I think, there's a lot of different courses in human-centered design. And then I think a lot of it is being mindful of the patient population that you're interacting with. As an example, somebody that is working here right now doing human-centered design for people who do not speak English as their first language. There has been a lot of thought around where they meet, how frequently, that the sessions that they'll be held will be in Spanish, and that the work is translating it into English for the researcher, but do that off time, like the things that help really for the groups that you're engaging. So I think it's an important question. I think learning the tools and then trying to figure out how it fits that community best is good, and engaging the community to find that out each time. I think as researchers for the groups that I've been involved in, we've learned something from the groups that we never thought in terms of where they would want to meet, if they want to meet in person versus virtual times, etc.
Rubina states that her research areas in HCI and usability evaluations of digital technology for clinicians and patients. Users are definitely at the center of the system development lifecycle, and what they have learned is that combining various methods such as experts, that is heuristic evaluation, and user testing helps us identify and address a wide array of issues.
Yeah, absolutely. I think that's an important thing. It's another thing around human-centered design can be used for all sorts of users. So they certainly can be used with healthcare delivery, with industry, with technology, with various interest holders. It doesn't have to be patients alone. I think we've been focusing on patients in the public because we don't want them to get left out, because it's the easiest group that seems to often get left out or tokenized where there's only one. And so thinking through, I think being really thoughtful about how to give that voice. So as an example, in the group with Willie Horner Johnson around people with intellectual and developmental disabilities, one of the things that the community group actually came up with was that they wanted a representative from the community that would be their central go-to person, so that they could talk with that person at any time around questions, or they wanted to have voice, etc. That person, that was one of the mechanisms that they used to ensure that everybody felt comfortable and had a mechanism and their voice would get heard. So I think when you start bringing in other interest holders, I think it's always helpful as well to think through how to do that in ways that the power dynamic still works.
Gretchen asks, where do you start with HCI? As in, how do you ensure you are asking the right question?
Yeah, it's interesting because often if we think about with like the learning health system science K-12 or the P30, you already have an idea. And that can be really hard, right? Because in an ideal world, you're wanting to go out and find the needs of the community and then build something. I think being able to put aside the idea and being open to that beginning stages of the empathy and the need so that you do have that opportunity to rethink what you're starting with can be very helpful.
All right, we have time. We have 2 more questions. We will get through them in 3 minutes. Mary Butler asks, how do you bring in people who are responding to their own urgency bias and don't want to take the time to do human-centered design as well?
See, this comes down that time. Time is always one of our big enemies. I think, I don't know how to answer that as far as I think part of why we've come up with the human-centered design is the thought that it is a mechanism you could use to make sure that you're engaging patients throughout the life cycle and giving attention, and maybe not starting right out with the CBPR as something that is a step that embodies the flavor, but is still doable. I think it's always going to be hard if not everybody's going to be a believer in how they engage with whether they even engage with the patients and the public.
And our last question is from Amy. What are your thoughts on narrative medicine? That is, patients tell a story about their symptoms and the strategies, listening to open-ended questions, do not interrupt, etc.
I love that. Yeah, I love that. There is actually a group, and it's out of the UK, and there's 2 centers here in the US. And I just can't think of the name, but where there's a whole library actually of narratives that patients have put together around various diseases, around their experiences in healthcare, their experiences with diagnosis versus treatment. And I think we don't use that enough. Like, it's created as a library of narratives for research purposes. I know there are experts, and it's not me in terms of how to use that, but there are huge libraries that I would love to see us use even more and contribute to even more. I know there's a whole discipline around how to do that well.
All right. Well, thank you so much, Dr. Guise. That was fantastic. And this concludes our presentation. And thank you, everyone, for joining us.
Thank you so much.